Yeah, good evening all. Pallavi ma'am, should I start? Yes, good evening all. On behalf of MAHA, I, Dr. Kundan Chopde, EB MAHA member, welcome you all for this third episode of Subspeciality Spotlight. And today's spotlight is on hematology and oncology. All our subspecialty spotlights are coming on auspicious days. First, cardiology was on Ganesh Jayanti. Second, endocrinology was on Shiv Jayanti. And today is Gudi Padwa. सो सर्वांना गुढीपाडव्याच्या व नवीन वर्षाच्या शुभेच्छा. नवीन वर्ष तुम्हाला सगळ्यांना सुखाचे, समृद्धीचे व भरभराटीचे जावो. I welcome all the office bearers of MAHA-IP, EB members of Central IIP and MAHA-IP, and today's expert Dr. Nitin Shah sir, and also today's speaker Dr. Atish Bakane sir, Dr. Tushar Idate, and Dr. Liza Balsari ma'am, and all pediatricians who are joining online. I am Dr. Kundan Chopde, today's moderator and course coordinator, along with Dr. Bhupesh Bond of this subspecialty spotlight. And the program advisors are Dr. Nikhil Pathak and Dr. Ravindra Sonone. Without wasting much time, I would like to hand over mic to MAHA-IP, first elected MAHA-IP President Dr. Sanjeev Doshi sir for his opening remarks.
गुढीपाडवाच्या या पवित्र मुहूर्तावर मी महाराष्ट्र आयपीच्या समस्त सदस्यगणांना खूप खूप शुभेच्छा देतो. Respected Nitin sir, the subspecialty spotlight team, Dr. Kundan, Dr. Ravi, Dr. Nikhil, Dr. Bhupesh, our dynamic secretary, Dr. Renu, today's speaker, Dr. Atish, Dr. Tushar, Dr. Liza. I welcome you all on this virtual platform of Maharashtra IP. मित्रांनो, महाराष्ट्र आय पी ला आपल्या स्वतःच्या स्टेटचे नितीन शाह सरांसारखे जे एक्सपर्ट लाभलेले आहेत ते खरोखरच आपल्याला एक वरदान आहे. I extend my humble salutation to Nitin sir for accepting our invite. मला नितीन सरांचे जे हिमॅटॉलॉजीचे जे लेक्चर आहे ते आधीपासूनच खूप अट्रॅक्ट करायचे. इवन ज्या काळामध्ये आपले मोबाईल्स नसायचे, so I used to record sir's lecture on those those tiny recorders. And thank you, sir, for your relentless, untiring services to the academy. And recently, I have gone through the life journey of yours in Mumbai, and really, sir, you are the torchbearer. You are inspiring to my contemporaries, to my juniors also. So it's really a great honor to welcome Nitin Shah, sir. Also, I welcome my
Thank
dear
you,
friend
sir. Thank you.
Atish, who is pioneering bone marrow in Nagpur, also Dr. Lisa and Dr. Tushar, and I extend warm welcome to all the attendees on this virtual platform. Uh, सगळ्यांना गुढीपाडव्यासोबत हिंदू नववर्षाच्या शुभेच्छा. आणि आता 2 दिवसातच ईद पण येत आहे, तर सगळ्यांना ईद मुबारक सुद्धा. सो ओव्हर टू यू रेणू.
Yes, sir. Thank
हॅपी
you.
लर्निंग.
Yeah, Dr. Renu madam.
नमस्कार. नवीन वर्षाच्या सगळ्यांना शुभेच्छा. आणि आजचं हिमॅटो ऑन्कॉलॉजीचा जो आपला एपिसोड आहे सबस्पेशालिटी चा कनेक्टचा, तर आय एम व्हेरी मच हॅपी दॅट डॉक्टर कुंदन अँड डॉक्टर भूपेश हॅज टेकन व्हेरी मच एफर्ट्स टू join all the speakers and also our expert Dr. Nitin Shah sir. Salute to you, sir. Teachers of teacher you are. And yeah, so also congratulations for your felicitation that was done in Mumbai IIP installation program, though I couldn't come due to personal reasons. And also I would like to welcome Dr. Atish, Dr. Tushar, our own from MGM Medical College, CSN, and Dr. Lisa. And expert opinion will be given by sir after each talk, and also at the end he will sum it up in his versatile manner. And also I would like to say gratitude to God to have this platform for all the young IAPNs who can have their whatever programs, they can do it through us. And many of them should come forward and also contact our MAHA EBs or OBs through WhatsApp or calling, that whether they are interested in what programs, or they can consult their city branches office bearers, and also they can convey to us. And also our Go Anemia Go program, it is going on very very good, and I would like to also congratulate all the OBs of MAHA city branches, that they should continue it till the month end, so that we will rock it. And we know that there are few prizes here for surprise, so best wishes for that also. As being the hemato-oncology, I just went to the Go Anemia Go program. So over to you, Kundan, for the
Yes, ma'am. Thank
further
you.
proceeding. Yeah.
Yes, thank you, ma'am. Dr.
Just
Sagar
to
Bhagaram sir is
just
here.
to apprise Nitin sir about this Go Anemia Go program, sir. As you being a towering personality in the field of hemato-oncology, and this Go Anemia Go, we have launched at the, each and every district level, and most of the district branches they are doing it very actively. They are conducting multiple camps and HB estimation program. Our academic partner is CIPLA, and we really want to target the preschool going children so that we can conquer our anemia very effectively, and Maharashtra IP could be the face in the community for eradicating or minimizing anemia in the preschool age children.
Yes, sir.
So
Thank you, sir.
that's a very good thing that you have done. I think anemia is a silent disease. People worry about anemia. I think my more worry is the non-hematological manifestation, especially cognitive dysfunction
Cognitive.
in a
Yes, yes.
growing child. So if you can tackle it very early and take the corrective measure, preventive measure, that will go in a long way. So I really congratulate all entire Maharashtra IIP for looking into this very very important topic.
Thank you, sir. Joint Secretary Admin, your quick comment, sir.
Good evening, everyone. Hello. Good evening, everyone. Happy New Year and Happy Guru Padwa and all the best team MAHA. Thank you.
Thank you, sir. Dr. Belawar, madam, scientific convener, your opening remark, ma'am.
Good evening. I'll say only one sentence. Wherever Dr. Nitin Shah sir is there, we can be assured of excellent discussion and academics. So let's just start the program. Thank you.
Yes, thank you, ma'am. I will just give the outline of today's program. That is, first talk is by Dr. Atish Bakne sir on recent update in hemoglobinopathy curative options. Second will be by Tushar Hidate sir on why we miss cancer in children. And third will be by Lisa Balsare madam. And that after each lecture, there will be comment by Dr. Nitin Shah sir. So I will just introduce everyone in the first so that academic program will roll over. Madam Pallavi ma'am, can you share the CV? Dr. Nitin Shah sir, I will just introduce. I am sure that all MAHA
Continue. No need to introduce me. Just
Yeah,
let
yeah,
him,
Dr. Nitin Shah sir.
let Dr. Atish start the talk, I think. Just
Yeah, yeah,
introduce these young people. Yeah.
yeah. Thank you, sir.
Don't worry about me.
Yes, sir. Dr. Atish Bakane sir has done MBBS from JMC Nagpur, DCH from KEM, and DNB from Chennai. He has done FNB from this Gangaram, Sir Gangaram Hospital, and he is working as a senior consultant in Nagpur, and he is also director at Ray Hope Center and various hospitals like New Era, Kingsway, Colors in Nagpur. He has done first successful bone marrow transplantation for thalassemia and sickle cell disease in Vidarbha region, and he is associated with NGO working for tribal areas, and he is recipient of Outstanding Young Achievers Award of Academy of Medical Science Nagpur, and he has various publications to his name. I will just introduce other speakers also in the same go. Dr. Tushar Idate is the associate professor and in charge of pediatric hematology and oncology at MGM Hospital, Chhatrapati Sambhaji Nagar. He is director of Orchid Hematology Center, and he has done his MBBS from BJ and MD from Sion. and he is at fellow pediatric hematology from Tata Memorial Hospital and Apollo Hospital, Delhi, and he is awardee of American Society of Hematology and Fellowship. And Dr. Lisa Balsare ma'am has completed his PG in pediatrics and done prestigious fellowship in pediatric hematology from Sion, Mumbai. She has been awarded as PDVAF. She maintains robust research portfolio with 56 publications to her credit and co-authored 5 patents filed with Patent Office of India. And she has initiated and conceptualized 3 comprehensive thalassemia major daycare center across Maharashtra, that is Pune, Nagar, and Amravati, and this center provides crucial free of cost chelation and comprehensive care for approximately 300 thalassemic patients. So we will first move to our first talk. Dr. Atish, you can share your slides. We are running 5 minutes late because of this technical error. Dr. Atish sir, you can share your slides. Make it, yes sir.
Humble request all the speakers to please stick up to your time. Huh?
Yes. Sir, slides are visible.
Yeah.
Just make it full screen, sir.
It is full screen. Atish, you
Full
need to
screen.
just say continue to share. Just say
Continue to share.
continue to share.
Just click that one.
Continue to share.
No, it has 1 minute.
Till then, you won't be able to move your slides.
Yes.
Yeah, perfect.
Perfect.
Oh, is it moving? It's not moving. Yeah.
Yeah,
yes,
it's moving. It's moving.
Oh,
So,
wonderful.
it's happy Gudi Padwa to everyone and everyone, and thank you so much for giving me this opportunity, Team MAHA, particularly Sanju Joshi sir, and all team members of MAHA. It is indeed a privilege, to talk and share platform with our inspiration like Nitin Shah sir from our pediatric days. We have seen him working and learned many things from his talks. And about Joshi sir, he's a guide when I shifted to Vidarbha region from Delhi, a guide and a mentor in many things. Always, words of wisdom from him usually help us. So I will try to cover this topic of curative horizons in hemoglobinopathies in 12 to 15 minutes. It's a difficult job, but I have tried to make this PowerPoint which will that would be more useful for general pediatricians. So what we'll cover is thalassemia and sickle cell disease burdens. What is the limitation of conventional care, quality of life? What is the referral window? What are basics of hematopoietic stem cell transplants? And what are complications and what is pediatrician's role post transplant also? And obviously a word about gene therapy. So we know immunoglobulopathies that it's almost very common. It's a very common birth defect. Third common birth defect it is seen in and most common genetic disease worldwide. Particularly in our area where I research from, the sickle cell disease and thalassemias, it's a huge. Every fourth or fifth house you will see at least a carrier of thalassemia or sickle cell disease. Almost 3 lakhs children are born with sickle cell disease in the world and 60,000 births are for thalassemia. In India, almost 10,000 per year still continuing to you know get birth in India despite so many measures from Indian government and NGOs. Despite that, the burden of thalassemia and sickle cell disease is almost the same because they are seen in mostly in tribal areas or thalassemia particularly sickle cell particularly in tribal areas. Thalassemia is seen in many areas in throughout India. So about thalassemia, we know there are some genotype phenotype correlation, and some are non-transfusion dependent to the continuum of highest transfusion dependent thalassemias who the children who require blood transfusion to survive. So yes, they have to be transfused lifelong, and we know with the regular blood transfusion, iron accumulates in the body and gives rise to lot of problems everyone is aware of. So what are the treatment options? Supportive and curative options. So supportive treatment I will not be talking about today. So my role will be to talk on allogenic stem cell transplant and gene therapy. So, so it's doctor's dilemma always there. So what should be done? Is the supportive care good or bone marrow transplantation good? So there is no direct answer to this, but yes, with improvements in supportive care like good transfusion strategies, good iron chelation, good endocrine and multidisciplinary management, the outcomes are definitely improved. But still, there is a long-term toxicity of iron and poor quality of life. So, what about hematopoietic stem cell transplant? Yes, with the high resolution HLA typings, new drugs, the concepts of conditioning have evolved. Better monitoring is available. Anti-infective treatments are available. Better understanding of impact of iron toxicity. So this has improved the outcome of transplant, but still, to some extent, there is transplant-related mortality, GVHD, infertility. These are still the burning questions. So there is always a dilemma. So 2017 EBMT activity survey, what reported was the indications of benign transplants are on the rise from early 90s to 2016. That data was. If you look at Indian stem cell transplant registry, almost one third of the patients are hemoglobinopathies, and they are even increasing. What was very much evident from paper by Syed Mohammed was the thalassemia major should be transplanted as early as possible before the organ damage and iron overload related complications begin because outcomes are good. So talking about hematopoietic stem cell transplant in hemoglobinopathy, it is the only widely available curative option today. I'm talking widely available because gene therapy is yet to come in India. It has been, yes, I will talk about it, what's the status. So why we do bone marrow transplant? We are going to replace faulty hematopoietic stem cells with healthy donor cells. Donors, most of you will be aware, like matched sibling donor is always better. It's a platinum standard. The matched unrelated donor that we get from registries is also on the rise, and the outcomes are almost similar. Haploidentical transplants in benign diseases, particularly hemoglobinopathy, is still a clinical option, not the standard of care. So matched sibling donor remains the standard platinum standard. But what? So only 25% of patients are matched sibling donor. So what to do for them? So that is why science evolved and matched unrelated donor and haploidentical transplants came into picture. What is more important is patient selection for thalassemia. No, it is not the bone marrow transplant. It is not just hematologist's job. It is equally or more important is pediatrician who was managing the child initially. Because if you look at this Pesaro classification that we use for transplant, if there is hepatomegaly, there is liver fibrosis or chelation history is poor, the outcome may not be as good. So we classify them as class 1, class 2 and class 3. So class 3 the thalassemics, they do not do well despite transplanting, even in matched sibling donor transplant. Why? Because they were not properly given transfusion or not properly chelated and not properly monitored. So iron overload is definitely a huge risk factors. What India gave to the world in the sub classification of class 3. Why it was needed? Because in India we see lot of class 3 patients. So in class 3, Vikram Matthews sir and team CMC, they categorized into two groups. Like if age is more than 7 years and liver is more than 5 centimeter below the costal margin, the outcomes are not going to be bad. They are going to be absolutely, see the difference, huge difference between the overall survivor and EFS. So that is the India's, Vikram Matthews sirs and India's give to the international community. So what is if a child is eligible for transplantation? If age is less than 12 years and if matched sibling donor is available, we can still consider HSCT, manage them well and go for it. But if matched sibling is not available, consider unrelated or cord blood or haploidentical transplantation in few situations. But if child is more than 12 years, if there is still well chelated child, matched sibling donor can still be offered to that child. But if it is if there is no matched sibling donor available, consider gene therapy. Obviously in India it's not there, but in such patients also we have to prepare them very well, go for a lot of pre-transplant immunosuppressions. You chelate them for 6 months to 1 year and then we can take them for transplant. So they are case to case basis. In sickle cell disease, patient selection is very important because sickle cell disease did not get much attention, unfortunately, for long, particularly in consultation with hematopoietic stem cell transplant, because it's restricted to some area or for other obvious reasons. So, but yes, being from the same area, what I can see is like almost 5 to 10% of the patients fall in this criteria. So if the patient has developed stroke or CNS symptom more than event less than lasting more than 24 hours, recurrent hospitalization, multiple acute chest syndromes, recurrent VOCs, impaired neuropsychological function, lung disease, any end organ damage like sickle nephropathy or proliferative retinopathy, osteonecrosis of multiple joint, red cell aluminization. And recently, there are people, if my sibling is available and if child is just symptomatic, they are missing school, they also are being taken. There is the update, the guidelines for sickle cell disease transplant will be out soon in the under the aegis of ICMR and your Indian transplant community. So, what is the process of bone marrow transplantation? So it's easy flow diagram. If you see, we have to select the patients as we discussed earlier. We have to select the donor. If the donor is a lot of things we have to do before investigations and matching. If it's done, then we give some conditioning to the patient. Some conditioning means the chemotherapeutic agents to destroy bone marrow and immunosuppress them, so that new immune system can be tolerated well and accepted in the body. That is conditioning. We give some GCSF in patients to the donors for harvesting stem cells if you are doing from peripheral blood or sometimes from bone marrow also. And on day 0 we call it as the infusion day or bone marrow transplant day. We infuse the product. Subsequently we wait for the engraftment, like when the neutrophils increase more than 500 for 3 successive days, platelets more than 20 or 50,000 depending on different definitions, and that is called as engraftment. So conditioning regimen, there are different conditioning regimen that is out of scope of this discussion. Graft versus host disease is very important to discuss because it is a nightmare if it happens, and particularly grade 3 grade 4 in any type of transplant. Supportive care during transplant is very important, and long term follow up also, in particularly in pediatricians perspective. So talking about the historical aspect, thalassemia was first transplanted in 1980s, and the child, that first transplanted person is still alive and doing well. In Pesaro group and Pescaro group came with transplant initially, huge number of transplant. The outcomes were phenomenal, particularly matched sibling donor transplants to the tune of 80 to 90% overall survival and event-free survival of almost 75 to 85%. Subsequently, lot of other investigators and transplanters changed a bit of conditioning and protocols. The any outcomes remained same. So thalassemia became the transplant in thalassemia became the standard of care. But what about sickle cell disease? There are two questions, very burning questions in sickle cell disease. What happens to those patients who are not in follow-up of pediatricians? Most of these patients are not there because here and there we see that there are some sicklers who are still at 50 60 they are alive, but most of them are not. If you look at the look at the demography and PSM criteria, as not many mortality studies are published in sickle cell disease. There are some from Surat, some from Kerala. If you look at sub-Saharan Africa, the mortality rates are huge. Almost 25% of the patients they die within almost 20 to 30 years of the age. If you compare USA data and Indian data, in USA also the median life expectancy is around 42 years as compared to 77 years in the non-sicklers. So silent cerebral infarct, why I included this study, this slide is very important because we see the in definition stroke, but what is if there is no stroke? What happens to MRI? If you look at the MRIs, because last 3 years I'm seeing Indian the Vidarbhi patients, many patients have this silent cerebral infarct. They are not doing well in studies. Their IQ is poor. So this is very important because this is happening in sickle cell disease. Yes, we know there is a wonder drug, hydroxyurea in sickle cell disease. A lot of other drugs came like crizolizumab, oxalator, which has been taken off because of increased mortality in few patients. But these therapies are not curative. So what can be done for the patients whom I told that these can be transplanted in sickle cell disease? So first sickle cell disease transplant are done for acute myeloid leukemia, and the child had sickle cell disease also. After after transplant, it was evident that sickle cell disease also got cured, and patient did not develop any VOCs thereafter. So conditioning I would not talk about. So what's the impact of bone marrow transplantation in symptomatic sickle? That is important. So what it does is it establishes normal erythropoiesis. It is associated with improved growth, stable CNS imaging, and pulmonary function in most patients. So there are huge number of patients that have been transplanted in sickle cell disease, and the outcomes are phenomenal. If you see the numbers, around 1000 patients, or out of them 846 were children. The outcome in sickle cell disease transplants are phenomenal. It is even better than thalassemia, because even if there is a mixed chimerism, that if somebody asks question, well, like we can discuss out that if there is a mixed chimerism, we can still sickle cell disease patients are free of blood transfusion and free of VOCs, and they can lead their normal life. So outcomes are absolutely fantastic. So if it is HLA identical sibling transplantation, there is excellent 5-year overall survival rate, rather lifelong survival rate. Age, graft type, and transplant period are critical prognostic markers. In Indian also, that what we have published in India, less than 16 to 13 years, the outcomes are good. The very important reason being the sickle cell disease, because microvasculature damage is there, and they have their liver affected to some extent, kidney affected to some extent, and transplant becomes a problem if you do them after 16. We can do after 16 years of age also, but the outcome may not be good. We have to change the conditioning. So early referral for transplantation improves outcomes. Reduced intensity conditioning, and there are some different types of conditioning. So both conditioning work, so we have to balance it in the bone marrow transplantation. Then mud. So in sickle cell disease also the same situation, because matched sibling donor is not available to the most of the patients. So matched unrelated donor transplantation come into picture with a similar success rate of around 80 to 90%. But there were some hiccups in matched unrelated donor transplants. Obviously, even if it's full match, it's not from your own family. So there are the chances of GVHD and graft failure a bit more. But yes, most of the investigators have proven that matched sibling donor and mud, if you do it in a proper way, the outcomes can be good. So then haploidentical. A word about haploidentical transplant. It is like a 50% match that we call, mostly done from a sibling who is matched or parents. Why it is important to discuss is because all patients have one donor available. Almost every child can have a donor. So initially outcomes were not good when haploidentical transplants were started in by European group in sickle cell disease earlier, the 46% rejection rate. But next 10 years the rejection rates have come down to 1 to 5%, as good as matched sibling donor transplants. And so it's not about the type of transplant, but it's about the age you are doing, how you are doing. But yes, this there's one more thing I would like to add is like alternative donor transplant, haploidentical transplant. There are different ways to do it. One way is like alpha beta T cell, alpha beta CD19 T cell depletion. Some people CD45 RA depletion also can be done. There are some jargons, but yes, in some patients we definitely need it. We select these patients and select this conditioning or this type of transplants for particular patients, depending on a lot of things. It is not only a single parameter that we consider, multiple parameters we consider. But all said and done, for benign disease like thalassemia and sickle cell disease, matched sibling donor and mud are standard of care, but not haploidentical transplant. It has to be done in a controlled trial, or the center which is experienced, and it is just a clinical option at present. It should be very
Please,
clear.
can you wind up?
Yes, sir. So complications, we should know mucositis, VODs, acute GVHD. Lot of late effects can be there, like endocrine issues, infertility. Some patients, particularly in sickle cell disease, we have seen secondary malignancies, iron overload. So what is important from general pediatrician's perspective is like share care model. Early detection of lot of problems post-transplant like bronchiolitis obliterans, chronic GVHD, psychosocial support, which is not very much thought of in Indian perspective, but now our all units have psychosocial support. Immunization schedule, I think I would skip this. Dr. Nitin sir is there. He is the best person to talk about it or guide us about it. Then growth and endocrine monitoring, everything is to be monitored. So I think gene therapy, only one thing or one to two things I would like to add, last two slides. So there are two techniques, gene addition and gene editing, where one is lentiviral and one is CRISPR-Cas9 based, which are proven, and they are they are approved. There are few approved therapies, like in 2024 milestones we call them. The most of these patients, like if you talk about sickle cell disease, more than 95% of patients in trials were free from vaso-occlusive crisis, and more than 90% in thalassemia, they were transfusion independent. So it's called as aha moment for all these patients. But what is $1 million challenge in this? It's $1 million, because if you talk about Indian rupees, almost 20 to 22 CR is only for the product, and rest of the things, if you go to US or Europe, other so almost 25 to 30 CR, it's for one gene therapy. So out of question for even 1% of the Indian population. But yes, what is good is Indian. There are four groups working independently in India, CMC, Delhi, and elsewhere, who are very near to finding a good gene therapy for us, which will be available to us, which will be affordable. That is very important. So what's the dream? If a single IV injection that can edit cells directly inside the body, that will be dream. And yes, that is also in trial, early phase 1 trial. So, to conclude, what I would like to say is we are no longer just managing hemoglobinopathies. Early referral of these patients to a hematologist definitely will, give you better survival. You can manage in your setup, but take opinion from hematologist intermittently, so that they can be kept better till either they can be transplanted, or they can, gene therapy is available. So I would like to say that pediatrician is the gatekeeper to the cure of these hemoglobinopathies. I think I think with this, I would like to thank you, Team MAHA once again, and thank you so much. Any
Thank you,
questions?
sir. Thank you, sir. Dr. Nitin Shah, sir, your comment.
Yeah, so you can stop sharing, Adish.
Yes, sir.
Yeah. So I think two important things which come in mind is that number one, as far as the pediatrician is concerned, they need to understand that the survivals are definitely based on the correct therapy given. If you under transfuse, if you under chillate them, you give them unsafe blood, and then you try to then send for transplant, the outcomes are horrible. So a net tested blood, a leukodepleted blood, which minimize the HLA sensitization, do their ferritin right from say one to 1.5 years of age every 6 months. Keep the ferritin tight at between 1000 to 1500, if possible below 1000. Use the maximum dose of the chelator so that you give to Dr. Atish or the transplanter a person who is having absolutely no risk factor for the transplant, which means no hepatomegaly, good chelation, and there is no liver fibrosis. So I think that is the most important message to the pediatrician. And yes, every patient feels that the gene therapy will come tomorrow, and but gene therapy will come tomorrow provided the child is kept well. So today you treat the child well, tomorrow transplant can happen. And with haploidentical, where one of the parent is always available, I mean, the Chinese people have the ones who have opened our eyes on haploidentical, because they had only one child family, there was no sibling donor available. So with the better availability of cyclophosphamide based conditioning and post conditioning use of cyclophosphamide and the T cell depleted marrow, I think the outcome of haploidentical is as good as a HLA match donor. In fact, there are some centers in Bombay whom I know, they will not break their head for thalassemia with a mud match unrelated donor. They would, if the sibling donor is not available, they straight go for haploidentical one of the healthy parents. But that's all provided you have treated the child well. And I think that's where there are questions about new drug like thalidomide. I'm sure you must have heard a lot of some one particular center using a left right center. It's still not the standard of care. It should be used only under the research mode. And I am aware of at least one trial going on with Borivali Center and Delhi Center use thalidomide in a controlled manner. And if that shows safety, we have had patients of thalidomide coming with either aplastic anemia or coming with secondary malignancy. So we are very scared of using the drug haphazardly, especially with transplant available. I think we should not venture into drugs which can be having trouble in tomorrow. As far as sickle is concerned, start hydroxyurea as early as possible in their life. Start them on oral penicillin as early as possible. Give them all the pneumococcal vaccines so they don't have pneumococcal sepsis, which is the most important thing. And don't forget folic acid, because they have a very rapid turnover. With this, you can actually cut down on a lot of uh, vaso-occlusive crisis. The sicklers in India are not as bad as in Africa. So we don't see too many complications unless they are not managed well. So good hydration, avoiding hypoxia, giving them correct dose of hydroxyurea, folic acid, and oral penicillin, and then give them the choice whether they would like to transplant the child, especially given the indication as Dr. Atish showed, the ones which are behaving severely, they are the ones who can be actually then transplanted. So I think with that, we will move on to the next topic. And I think let's invite Dr. Tushar
Yes, sir.
to speak on why we miss cancers.
I will share my slides.
Yes, sir.
Yes, please.
Atish sir, there are some questions we will take at the end of the talk.
Yes.
All three talks completed, we will take the questions.
Absolutely, yes, sir.
Tushar, share your slides.
Can you see, sir?
Visible, sir. Make it full screen.
Full screen.
Yes, sir. Make it full screen. Slideshow.
Now?
Yeah. Visible, sir.
Yes, properly visible. Okay.
Yes, yes.
So good evening, everyone, and thank you, MAHA IP, for giving me this opportunity to share my views. And it's always fun whenever the talks are with Dr. Nitish sir, and we definitely get to learn from sir. Without wasting time, I will go to my topic, which is basically sort of a talk about awareness about the cancer in children. So overview of the talk will be, I'm going to take few of the cases to keep it, sort of interesting. Simple real cases which we have actually managed. I have included only hemat cases, not the solid tumors, because hemat cases are the ones which form the 50% of the pediatric cancers anyways. And only basics of the pediatric cancer therapy I'm going to cover, not the in detail discussion. So these are the cases which, sort of pediatricians have seen and being referred to me. So 7-year-old male child who presented with a progressive swelling in the neck since 6 months. He had no fever, no weight loss, no pruritus or any other symptoms. But there was a history of coughs in the maternal, some distant relative. And CBC was normal, ESR was normal. X-ray chest and USG abdomen was normal. And this was the lymph node. So this is a bulky node, as we can see, more than 5 centimeters in a otherwise not so sick child. So what will be the plan of action? So this is where we sort of, miss this patient. A few of these patients are started on empirical anti-cough therapy. A few of them undergo FNAC, and only few of them will go for the biopsy. So the problem with the, I think, compared to the 10 years before, now empirical AKT, not many people are starting, so that is not a major issue. But the FNAC remains an issue. The problem with the FNAC is that if you hit an area where the cells of the disease are not there, then you may miss the diagnosis. That is the first thing. And second thing is that you may not get the whole architecture of the lymph node. And if you have to do the further test like immunohistochemistry, the sample is never the adequate. So anyways, you end up doing the biopsy. So the best and the only thing which should be done is the lymph node biopsy, that also the excisional biopsy where the whole of the lymph node is taken out, where we can do histopathological good examination, and then if required, we can go for the IHC also. So this is one thing I just wanted to highlight. So this patient biopsy was confirmed to have lymphoma. Then staging investigations such as PET-CT and bone marrow CSF were done, and the child was started on chemotherapy and supportive care. So the lymphoma constitutes 10 to 15% of the pediatric cancer, and most common types are Hodgkin lymphoma and non-Hodgkin lymphoma. In Hodgkin lymphoma, prognostic factors are at what stage you are diagnosed, if it is a bulky disease, lymph nodes are big or not, if there are B symptoms like fever, weight loss, or night sweats. One, what is the response to the treatment after 2 cycles of the therapy? So for staging, we use PET-CT scan, and treatment is just chemotherapy. Usually, we don't require any chemotherapy. And radiation is also sort of going out of the protocol for the Hodgkin lymphoma patients. So protocols have evolved over the years. However, Opdec is something which is routinely used. And most important thing is there is huge difference in adult and pediatric protocols. And because the pediatric patients have got very robust outcomes. As you can see, there are more than 90% outcomes in stage 1 and 2. Even in stage 3 and 4, they are more than 70 to 80% outcomes. So coming to case 2, a 12-year-old boy who presented with coughs in 7 days, a respiratory distress since 5 days, and edema over the face. So on examination, child had tachypnea. Child had a dilated veins over the neck. Saturation of O2 was 85%. With O2, it went to 98%. And there was significant generalized lymphadenopathy. Respiratory system examination, there was heredity was equal on both sides, and there were no any crepitations or any additional sounds were not heard. But on examination of abdomen, there were liver and spleen both were palpable. So the prima facie 2-3 differentials come to our mind. One is yes, it can be infection or sepsis. Second, as usual, the tuberculosis will remain one of the differential. And third, which comes to oncologist mind, is again the malignancy. Okay. So here definitely we'll like to do the basic labs like CBC, liver function, kidney functions. And along with that, because the malignancy is in the mind, maybe tumor lysis markers also will do. And of course, because the symptoms are related to the respiratory system, X-ray and CT scan will be done. So this is the X-ray imaging. And as you can see, the superior mediastinum widening can be seen here. Usually, the mediastinum shadow is not more than 1/3 of the area of the horizontal diameter of the chest. But here you can see it is covering almost 50% of the area. So that is called as mediastinal widening. So when you get a mediastinal widening, or sort of if there is anything which is compressing the superior mediastinum, there are two vital structures which are there. One is your trachea and second one is your SVC, that is superior vena cava. So whenever the compression is there, these patients will have certain symptoms, such as dilatation of the veins and edema over the face, and it will lead to the respiratory symptoms such as cough, respiratory distress, dysphagia, and pleural and pericardial effusion also can be there. When it can be seen in non-Hodgkin lymphoma, TALL, germ cell tumor, various sarcomas, and sometimes in neuroblastomas. How do you manage these patients? Whenever you don't have a diagnosis, but yes, you suspect, in your setup as a pediatrician, these are the things which you can easily do before you refer the patient. Okay. Definitely, you should have a suspicion of malignancy. I just want to highlight this second case also in a proper way. That if you have got a respiratory system patient where you don't have anything in your sort of conclusive relating to the tuberculosis, definitely you should have a suspicion of malignancy. You can start the patient on supportive care oxygen, high head and elevation. You have to preferably put the IV line in lower extremities because upper extremity will drain through the superior vena cava, which is blocked. So it will sort of, cause overload. And you have to reach to the diagnosis with the least invasive method because these patients are already compromised. Their respiratory airway is compromised. So if you give sedation for the diagnostic purposes, they just collapse. So you have to try to sort of get the tissue or the pleural fluid you can send for the investigation. Sometimes when you do CBC in these patients, WBC count is very high. It is more than 50,000 to 1 lakh. Then you can send the blood for further investigations. You can have a peripheral smear look, and then further investigations can be done for the blood. So the point is that you have to avoid sedation and try to reach to the diagnosis with the least invasive method. And whenever you reach to a diagnosis, the treatment will remain. If it is a lymph node malignancy, you can start with the low dose steroids and gradually sort of you have to get the tumor under control. So this patient again, lymph node biopsy was done and T lymphoma was confirmed, and then staging and chemotherapy was given. Third case, interesting one. So 10-year-old boy from Parvani presented with abdominal pain and vomiting since 15 days. There was a history of fever since 7 days, and USG of suggestion of lymph nodes in the abdomen, largest measuring 2 into 1.5 centimeter, and mild free fluid in the abdomen. So again here, the investigations will roam around, enteric, some abdominal coughs, or some infection, all these things will go. Is there any obstruction? So after having all these things, when everything was inconclusive, the lymph node biopsy of the abdomen was planned because the patient had persistent high-grade fever and rest of the things were ruled out. And the basic investigations had only 2-3 positive points. One was LDH was done and uric acid was more than 10, around 10. and ascitic fluid was tapped, and fluid was suggestive of lymphopredominance, and it was sent for further analysis. So with all these things in the mind, the child underwent biopsy of the lymph node, of the abdominal lymph node, and it was suggestive of non-Hodgkin lymphoma. And then when the immunohistochemistry of the patient was done, it confirmed anaplastic large cell lymphoma, which is a subtype of non-Hodgkin lymphoma. And then again, the PET-CT scan was done to do the staging, and it was diagnosed as a stage 3 disease, and chemotherapy was started as per the ALCA19 and chemotherapy protocol. So non-Hodgkin lymphoma again forms after Hodgkin lymphoma, non-Hodgkin lymphoma. So these are the two major lymphomas. Non-Hodgkin lymphoma has got 2-3 subtypes. One is Burkitt, second is large cell DLBCL, and third is T lymphoma. Burkitt will generally present with abdominal lymphadenopathy, abdominal involvement. Most of the Burkitts have come to us with the symptoms of intestinal obstruction. So they will have presentation like ileocecal obstruction. That is a common area where it usually starts. So they will come with fever, abdomen pain, vomiting. They will go to the pediatric surgeon, and few of them will sort of, consider biopsy. Few of them will do the resection. And whenever the report comes, it is usually the Burkitt lymphoma. While the T lymphomas will present with an anterior metastatic mass, and they will, the way I have mentioned the second case, so they will come with the respiratory distress and anterior metasternal widening and mass. So diagnosis is based on histopathological studies, and further studies are required for the subtyping. And Hodgkin and non-Hodgkin, both, again, outcomes are very good. So this is important. When do you want to investigate the lymphadenopathy? Whenever there is a generalized lymphadenopathy. By generalized, we know that 2 or more non-contiguous areas are involved, and the size of the lymph node is significant. Okay. Any palpable supraclavicular, epitrochlear, or popliteal node should be biopsied. Node firmly attached to the underlying structure. Significant constitutional symptoms. Hepatic or splenic enlargement along with lymphadenopathy, very important. And child is unresponsive to your empirical antibiotics or period of observation. So when you get lymphadenopathy, you have to always examine liver and spleen. Rule out SVC. I have highlighted it enough. Look for pleural and pleural effusion and ascites. You may get fluid, and you may send these sort of samples for the further investigation, and they may clinch the diagnosis without even going for the lymph node biopsy. Now, this is the important and last case, very important case. And as I have mentioned, I have taken only the cases which I have seen and managed. And this I want to highlight very well. So 5-year-old girl presented only with difficulty in walking. And this is not the one patient. I have seen at least 8 to 10 patients like this. Complaints started with pain in the legs and gradually increased. Now the child is not able to walk. Some of them have brought the patients just like, in their hands. That child is not even able to go from एक करवट to second करवट, that kind of severe pain. But there is no associated fever. There is no rash. There is no bleeding. There is no swelling. There is no weakness also. And on examination, tone, power, reflexes are normal. There is no weakness noted in the limbs. No significant lymphadenopathy. Liver is not palpable. Spleen is not. Nothing is there. So the only complaint is leg pain. Not even the joint pain. It is a leg pain. Okay. Investigation. CBC was done, normal. Liver function, renal functions, electrolytes, everything normal. X-ray of the joints was done, normal. As expected, neurologist was involved, so EMG and NC was done, normal. MRI, brain, spine, both were done. Again, not much conclusive. Then finally, rheumatology consultation was done. Rheumatologist did some investigations. Uric acid was a little bit on a higher side, LDH was 2350. And this patient was suspected to have a systemic JRA. Now, apart from Dr. Nitin Shah sir and the hematologist, I want everyone to comment in the box. So this child was started on tablet prednisolone. Anything else you would like to do? I will waste my 1 minute over here, but do you want to change anything over here? I will go back because this, I think, will be the most important slide of the whole presentation. So there is nothing actually warning. Liver spleen is not there, lymph nodes are not there. There is no fever also. CBC is normal. And this clear cut looks like a JRA, and the child was started on prednisolone. Okay, I will go ahead. You can put in the.
Can you give the complete CBC for them? theoretically, even if you
Okay,
let
so
me say the hemoglobin is 8 grams,
around 8 to 9 grams.
WBC is say 25,000, 90% neutrophil, 10% lympho, and platelets are 6.5 lakhs.
Yes, sir.
Then that is JRA. If if the counts are not like this, then don't think of JRA, especially when you have rapid cell turnover, as you can see here, very high uric acid and a high LDH. This is not JRA. And don't give steroid without a marrow in such child. I mean, that is the
So, so these are the two things, sir has already mentioned. So two things take home. First, I'll finish the what happened to this patient, and then we'll go back. So after 3 weeks, joint pain was mildly reduced, but then fever started. And this point again, the CBC was done. And this point, CBC was deranged. HB was 7, WBC count 4,500 with neutrophil of only 10, lymphocytes of 90, platelet 50,000, and then referred to the hematologist. And then bone marrow examination, then full of blast. So the question is, can we change this story? If yes, how? So there are 2 points. One, as sir said, CBC normal means what? You see the CBC, you look at the WBC count, but you don't look at the neutrophil. So the WBC count might have been 8,000, but how many were neutrophil? Neutrophil might have been only 10. Remaining lympho 90 might have been the blast to start with. You ignored it. Platelet count might have been 1.2, 1.3, 1.4, which you might have missed. You did not look at the peripheral smear, which might have picked up the blast. Okay, all this is still accepted. You labeled it as a rheumatoid arthritis, no issues. Did you have anything conclusive for rheumatoid arthritis to label? No. So before you start on the steroids or something like steroid, at least that is the second point where we can sort of protect ourselves and our patients, that before you start on steroids, you should definitely do the bone marrow examination. I have from my own region at least 3 to 4 patients which were referred to Chandani sir as a cases of rheumatology. Sir just saw the peripheral smear, called me, Tushar, these are looking like leukemia. I'm sending them back because they are from Chhatrapati Sambhajinagar. You do the marrow, and they were all leukemia. So this is a humble request. I have taken enough of time for this particular case, and this is something very near to my heart. I feel that wherever I get the opportunity, I want to highlight this case. So the take home is that don't start steroids when you don't know what you are treating with. And second, always look at CBC in a crucial way along with the peripheral smear. So then again, further investigations were done. This patient was diagnosed to be BLL. And we know that fish and karyotyping, these are additional tests, flow cytometry, fish. And this is another point I want to highlight. Now, just doing the bone marrow examination doesn't solve the problem. You have to do the flow, fish, karyotyping, everything. Now, anywhere in the periphery, the marrows are being done, and then patient is being referred to us, and then we have to redo the bone marrow examination because the EDTA heparin sample is not taken and investigations are not sent. And again, we have to subject the patient for the bone marrow examination again for the second time. So if at all you are planning for the bone marrow at your local place, please take 2 additional EDTA and 1 heparin sample, so that flow cytometry, fish and karyotyping done from the same sample and preserve them in a good condition. And those also tests can be done only in 24, 48 hours, maximum 72 hours. So try to avoid getting into these things which will sort of push your patient for the re-examination. Then we classify these patients into standard, intermediate, and high risk. And I will not go in detail of the treatment and everything, but I will definitely like to highlight that there have been very advances in the therapy. And the red line I want everyone to notice that treatment of adolescents and young adults up to 30 years is inspired on pediatric protocol. So this is one branch where we have not copied the adult colleagues, but adult colleagues have copied the pediatricians. ओके जनरली काय होतं की अडल्ट मध्ये ट्रायल होते तिकडे चांगले रिझल्ट येतात आणि मग आपण कॉपी करतो. इथे उलट आहे की पिडियाट्रिक ल्युकेमियाचे रिझल्ट मोर दॅन 90%, 80% झाल्यानंतर अडल्ट have sort of inspired from these protocols, and these protocols are being replicated in the adult population because 5-year survival in children with ALL is more than 80% already. So when you have a suspected leukemia patient, there are some do's and sub-don'ts. First, do's. Understand that it is a hematological emergency and fatal within weeks without chemotherapy. You can definitely start on IV fluids, preferably without potassium and dextrose. Plain NS is a good option. Antibiotics if febrile, send blood culture and CRP if possible and feasible. Blood products can be given. There is another myth that, if one blood transfusion is given, then the leukemia will vanish. Yes, there are cases reported, but if you have a patient who has got HB of 3 and 4, and if you are referring from Nanded or uh, if you are referring from Solapur to Pune, like 250, 300 kilometers away, and the child is already on the verge of cardiac failure, child is going to die, or he may die when he reaches the hospital. So blood products can be given. Definitely, there is absolutely no issue if it is sort of indicated, but definitely without any steroids, no hydrocortisone or no dexamethasone prior to blood transfusion. Counsel the family about good prognosis and motivate them for therapy. Don'ts. What you should not do in undiagnosed cytopenia and suspected leukemia patients, please don't use steroids. No steroids prior to blood transfusion as a routine. Because why we are stressing it so much? Because it causes diagnostic dilemma. Sometimes you don't get the diagnosis, leukemia is masked, and then patient come after 15 days or 1 month in a flare disease. It increases the risk of infection and it causes resistant disease. From standard risk, patient is shifted to the high risk category. Don't avoid transfusion and stabilization prior to referral. So, last one slide. So, in pediatric cancers, we have treated more than 500 patients in last 10 years at our small center. This includes all the spectrum, and I'm very happy to share with you all that more than 70 to 80% outcomes are there in even in new centers like MGM Sambhajinagar, and there are well-established centers like Hinduja and Tata. They have got more than 85 to 90% outcomes. So, thank you everyone for listening to me, and if any questions, we are happy to take. Thank you.
Thank you, Tushar. Can you stop sharing your slides?
Yes, sir.
Yeah. You haven't stopped sharing still.
I think I don't have that option.
He doesn't have the option.
No, he can.
Uh,
Sir, go to the more and just click where you
Okay,
have
I
shared.
have done it for him, no issues.
Okay,
So
thank
I
you.
think very excellent cases, very eye-opener. I think that's something what pediatrician will not want to know. So one thing is weight loss. More than 10% weight loss is an important sinister symptom to say that this is not just simple anemia. Night awakening. A child who cries and gets up at night is not growing pain. Child who refuses to even bear weight, as Tushar's second case, is of course is a completely brain no brain required to diagnose. But even child who is certainly having pain but gets up at night with pain is a disaster. If you have started in a lymph node without any this one on AKT and he doesn't respond, don't think of MD or TB. Think that this is not TB, it is malignancy. Any superficial lymph node, it is possible to biopsy. Deep lymph node, you are worried about CT may not be available. It's a hazardous procedure to do an intra thoracic or intra-abdominal lymph node biopsy. But you have peripheral, like the first case had a massive lymph node in the neck. I mean, ultrasound guided biopsy is so possible. Then here, the telltale sign of dilated veins, superior vena cava syndrome. I think you should not mess around such patient because you make them even lie down. They may die, choke and die. And we have seen children dying in ward because they were not in the proper position. Pathologists do not see smears. Any abnormal count, please refer to some expert who can see the smear and diagnose blast. Uric acid LDH high is a cell turnover sign, very likely to be malignancy. Already stressed, do not give steroid or bone marrow or a blood transfusion unnecessarily. And especially the counts are low, like a close differential is SLE. Always a fight between rheumatologist and a hematologist. When in doubt, do a marrow. Doing a marrow in an older child is easier than putting an IV line in a preterm baby. And I'm sure all of you would agree. You may sometimes break your head for half an hour to get a vein in a preterm, whereas marrow, Tushar can do in 5 minutes time. If you have a pleural fluid, you can do flow from that. If you have a CNS infection, you can do flow from CSF. Of course, you can do flow from peripheral blood and so on and so forth. And last but not the least, Tushar mentioned about Hodgkin disease, the stage 3, stage 4 cure rates of 70-75%. But now with the monoclonal antibody nivolumab, the revolutionized the treatment to cure of more than 90%. So now in Hodgkin's, whichever the stage, with chemo and nivolumab, depending on the stage, you can actually achieve 90% cure rate, provided you refer them in time. Excellent presentation, Tushar. Let's move to the third and the last presentation of day. Dr.
Third presentation is on glass slide, sir. Detectives. Dr. Lisa.
Yeah, Dr. Lisa, correct.
Dr. Lisa, you can share the screen. Slides are visible. Slides are visible, but not moving. We are having rheumatology presentation in coming months as a subspecialty spotlight in next 1 or 2 months.
What happened? Lisa is not there?
She is there, sir. She is trying to connect this.
Oh, she didn't keep it open, her PPT?
Yeah, yeah.
Oh.
There are too many tabs are open. She is just connecting.
Sure.
Okay. I think I'm unmuted now.
Yeah. Your screen
Yes.
is slideshow is
Yes,
not
yes,
visible.
yes, sir. I'll just give me a second. Okay.
Yes.
Is it visible now? Yes.
Yeah.
So thank you, Maha IIP, for giving me a space to share it with my mentors, Nitin Shah sir and Bakkane sir, and definitely Tushar Idate sir. I've learned a lot of them. And I think actually the whole PPT is summarized by sir already when he said pathologists do not see smears. So probably we will have to go and see the smears because CBC is the most undervalued test. We order it for everybody, and it is a powerful screening tool, but we only see RBC, WBC, and platelets. Rest of the things which a smear can easily be diagnosed, which an automated count cannot, is generally miss. And it actually helps us to answer why this child is sick. So just when the number doesn't match the patient, trust the smear. So this is a case of ITP. These are 10 very rapid case presentations I'm going to do, which we see in OPD basis. So he is a 4-year-old boy, 1 week of fever, lethargy, and new petechial rash, no organomegaly, no lymphadenopathy. And hemoglobin is 8.6, count is 3530, and platelet is 6,000. And someone has reacted, the PS is microcytosis is present, platelets are reduced on spear, and large platelets were seen. So some ITP versus some viral suppression, which we are thinking. But this was the smear. As you can likely see, there were some abnormal cells alarming to us. So my aha moment for this is that the smear revealed a peripheral smear showed blast. These were not mature lymphocyte. The pancytopenia was due to bone marrow replacement by malignant cells. Definitely marrow was done. Flow cytometry suggested of AL, acute lymphoblastic leukemia. From management changed from observe and give steroid for ITP. We will not give steroids without doing bone marrow, but immediately an oncology consent and a bone marrow and a flow cytometry. As sir has rightly said, if you are doing a marrow, please take 2 ADT and 2 green samples and a biopsy sample because we do not want to repeat the marrow because the samples were not adequate. This is a case 2. It is a jaundiced newborn. He is a 5-day-old with persistent jaundice. Total bilis 18. Anemia is there 14.8. DCT was negative. Reticulocyte was high 15%, and MCHC was 36.5. Is it just ABO incompatibility, G6PD, and you have already sent an NBST, which is routinely sent? But the peripheral smear had a different story. There was no heme present, it was just spears. Small, dark, round RBCs and no central pallor. Polycremusia was present. A combination of high MCHC, prominent spirocytosis is basically a classic presentation. Organomegaly can be present. Final diagnosis hereditary spirocytosis after a genetic test. Definitely, you can also do an OFT, which could give you a quicker result. So, to rule from just to give a folic acid and rule out enzymopathy supplementation, we went back to family screening and education because hereditary spherocytosis comes with increased MCHC, which is a rule of thumb. You will have to see this. Spherocytosis on smear, a pale center of the normal shaped cell, definitely high retic count, negative DCT, which will rule out AIHA, and definitely family history. You will see that the gallbladder surgery must have been done, or the parents or the uncle will have a splenomegaly because it is an autosomal dominant disease. Now, this is a sick toddler, 2-year-old, sudden pallor, weakness, decreased urine output, 5 days of diarrheal illness. HB of 7.1, platelet was 1 lakh, and creat was 2.5. Now, AKI or sepsis, or AKI with sepsis, or DIC. So, basically, the smear. The smear has that helmet kind of a cell, which we call as cystocytes. Normally, cystocytes are not present. Even 1 or 2% of cystocyte in PS will be an alarm for an hematologist. So, this is an hallmark of MAHA, the triad thrombocytopenia, AKI, and definitely the hemolytic anemia present here. We cannot miss this. This is an emergency, hemolytic uremic syndrome. So the management just from the history was broad spectrum antibiotic. Now it became probably a supportive care or an urgent dialysis. We usually try to avoid platelet transfusion in this certain cases. Nowadays we don't see so many cases, but if you're definitely practicing in a background where such cases might be present, feverish traveler, 6-year-old, high cyclical fever 104, chills after a family trip, HB of 9, platelet of 90, and liver enzymes were elevated. Now, you see the smear, it can be a non-specific viral fever. You are thinking of typhoid fever, but then you see this smear and it is an unmistakable thing where you have to start the movement of the treatment immediately. The rings. The multiple ring form of trophocyte, which is a malarial ring. Nobody on earth can miss this. And definitely it is an emergency and we start the treatment as soon as this is confirmed. Definitely, we send the antigen, but before that, also the uh, medications are started. Now, coming to the most common scenario when an NHS 4 survey says 57.7% are anemic, we have a 9-year-old month who has a severe pallor. The mother says he has not been eating for ragi sattva khato and te khato. HB is 6, MCV is 55, RDW is high 25%. Either you start with a severe iron deficiency anemia protocol and put on in a 6 mg per kg iron, but then you see a smear. Now the smear has multiple cells, including the target cells. So basophilic stippling is seen, target cells are seen. Now MCV, as you said, we have discussed, it was little low for IDA, and target cells shows something else. We order an HB electrophoresis, then we order parents HB electrophoresis because we do not give a diagnosis in our state without parents HB electrophoresis, because it could be mother can be thalassemia trait, father can be sickle trait, and it could be just a mix of sickle beta thal, and you do not start transfusion regimen, regular transfusion regimen, you probably will be thinking of hydroxyurea and blood transfusion. So this is the plan which changes on PS, and definitely we just cannot start iron for this child as he is thalassemic. A 8-year-old sickle cell anemia come with a severe pain in his back and his chest, febrile episode of 101, HB of 7.2, WBC of 18.5, and retic is high. You know this is vaso-occlusive disease. You order a PS, you see sickling percentage. Please, for any sickle cell anemia, when he comes in sickle crisis, please do an HB electrophoresis before you transfuse blood or start fluid, because we need to know the sickling percentage, because the treatment protocol will change. As soon as the sickling percentage is very high, probably you will have to do start and exchange transfusion as soon as possible. So the only point to prove with this sickle case was to do HP electrophoresis when they come with vaso-occlusive crisis or acute chest syndrome. Please do the sickle percentage as that time. And definitely we'll start aggressive hydration, pain control, oxygen, and antibiotics for this child. The bleeding teenager. These are all the cases we have seen in our practice till now. 15-year-old with severe gum bleeding, epistaxis, and extensive bruising for 3 days. WBC was 2000, HB was 7.5, platelet was 20,000. PT apetite normal, fibrinogen 50, D dimer was high. Initially, severe sepsis because he has fever, epistaxis, bruising, or with the IC. But this is the peripheral smear. Now, as you can see, This is a beautiful peripheral smear where the visible diagnosis is screaming at us. So this is an abnormal promyelocyte, which has a heavy granulation with multiple iron rods, which we call as faggot cells. अगर किसी ने iron rods लिखा है, please transfer the patient if you do not have a hematologist present. This is APML M3. This is actually an emergency. If we do not start the ATRA within 12 hours of the admission, we might lose this patient before even we have a diagnosis. And if we start, the cure rates are as equal to 99%. 100% की गारंटी मेडिकल में नहीं होती, वरना मैं 100% बोलती. So a PS, which we were thinking it is sepsis with DIC, a PS has actually changed into that I have to start ATRA, I cannot wait. Probably FFP and cryo support will be needed for this case because the bleeding is going to be extensive if not managed on time. I am pretty sure Tusharidate sir and Nitish sir has seen these cases left, right, and center in hundred of numbers till now. Coming to the other leukemia, a 3-year-old with persistent fever, bone pain, and pallor. Very similar to case 1. Now the WBC is high, 35,000, HB is 8, platelet is 40. Now I am thinking either is this leukemoid reaction or leukemia. Again coming to the same smear, but now the faggot cell, the iron rods, the crumpled part are lesser. 60% of the blast, and they are this blast are moderate, and they have a definitive chromative material which is iron rods. Now iron rods, definitely when I said iron rods cannot be missed, it is an unforgivable mistake if a PS reveals there is an iron rod and the pathologist had not mentioned. This is AML. When you diagnose a case of AML or anybody in your near patient group has an AML, please start saying the word transplant because probably he will require BMT and transplant. When we start speaking the word transplant as a curative approach in diagnosis, it is better for the patients to accept that. Otherwise, when we speak after the CR1, it is very difficult for the patient and the family to accept a transplant as the curative option. Now, this is the case which we had diagnosed in our practice. 2-month-old unvaccinated child with paroxysmal coughing fits. They were whooping, post-tussive emesis was present. WBC was 60,000 and 90% was the lymphocyte in this. We were thinking, is it viral URI? Because WBC is shouting at us as leukemia. When we saw the PS had cleaved lymphocytes. Now, when we looked back, the cleaved lymphocytes basically are the first sign that it could be pertussis. When a malignant looking reactive lymphocyte is cleaved, it is pertussis toxin. This patient was referred to us from Bhopal. We did not do a flow cytometry on peripheral smear, but after a week, the father sent us the report where flow cytometry was done and it was normal. So we started the basic management for pertussis with azithromycin, respiratory isolation. Patient is all right. WBC is also all right currently. The smear prevented a biopsy or prevented the child from a biopsy. Now, hepat and hemat always go hand in hand. Most of the time, we overcome the hepat part. A 2-month-old preterm baby born after third consanguineous marriage, persistent jaundice at the day of life 10. Day of life 15 had abdominal distension and hepatosplenomegaly was present. CBC was 6.1, count of 3400, and platelets were 3200, 32,000. Definitely, we thought of a storage disorder, but this is an actual picture of the lymphocyte which is showing us a vacuolation. So we discussed with Biradar sir, and sir said we will do the biopsy. The liver and the bone marrow biopsy was done. This is the NGS report, Niemann-Pick disease. Why this PS was extremely important for us was before the diagnosis, before the biopsy report could have come in our hands, because of an excellent PS pickup, we were able to counsel the parents the need of all the tests which we were prescribing because we wanted to prove what we saw. And definitely this PS was very important for us, because then we get to know that Niemann pigment type C, autosomal recessive disease. And probably this wouldn't have been picked up if it was not a very good eye. So this is the last slide which I really want to say. Blast, scant cytoplasm, high NC ratio, please think of leukemia. Spirocyte, small, dark, no central pallor, high MCHC, family history, hereditary spirocytosis. Cystocytes, RBC fragment, helmet cell, think of uh, MAHA or HUS or TTP. Parasites, always check the travel history, ring inside the RBC. Iron rods, always an emergency, AML and APML. Cleaved lymphocytes, pertussis and vacuolation, definitely the storage disorders. But I want today all of you on Gudi Padwa, when we start everything new, be like a Jagga Jasus. Please hammer for the smear. If you do not get a proper smear report, call up 3 times, but please order a peripheral smear with the CBC. With this, I end my talk. Thank you so much.
Yes, excellently summarized and good cases. Nitin Shah, sir, your expert comment. Nitin Shah.
Sir, can you please?
Sir, unmute, please, sir. Sir, unmute. Sir, please unmute.
If I'm given a choice to do only one test in a suspected hematological disease, it's the peripheral smear. Bedside costs 1 rupee. I can stay in myself, see under a microscope at my home or my clinic, and in more than 50% time, I can actually make a diagnosis, as was very aptly shown by Dr. Liza in the several smears. What we are seeing now is D negative HUS, not diarrhea associated, but they are all autoantibodies to the H factor, and you can actually do the antibody and put them on steroid, because that's the therapy. Like it's like an autoimmune disorder. MCHC is important not only to diagnose hereditary spherocytosis, but even in AIHA. If you have acute hemolytic anemia, MCHC is high because the RBCs are clumped, stacked over one another. And there's another smear where you can see rouleau formation on the peripheral smear, which is very starking, which cannot be missed. Plus the MCHC high will tell you it's AIHA. Iron deficiency, now we give only 3 mg per kg as per the consensus guideline by the IIP PHO and not 6, because that reduces the side effect and improves the compliance. Most of the thalassemics will come with very high count, 80,000, even up to 1 lakh we have seen. And they are all, someone has reported blast, but they are actually normal blasts. So when you see the smear, they are not the myeloblasts, but they are normal blasts. So always look for that, because the MCV is usually 60, 70, 75, not like iron deficiency where it's 50. When you have a low MCV and a high RBC, you think of thalassemia minor. But when you have a near normal MCV and a very high WBC count, look at the normal blast on the smear. Uh, if you have high WBC count, of course, one should be very worried. When I have a report of 10,000 WBC with 90% lymphocyte, by and large, those 90% are actually blasts, if there is also associated anemia and thrombocytopenia. And lastly, for the sickle cell, both for the talk by the previous speaker, Dr. Atish and Dr. Liza showed sickling. If possible, you should do an apheresis rather than plasma RBC exchange, because RBC exchange is manual, is hazardous. Whereas if you have the facility with the blood bank, you have an apheresis machine, you can actually plan apheresis by putting the pre-transfusion hemoglobin, post-transfusion required hemoglobin, pre-transfusion hemoglobin S, post-transfusion how much you want to dilute, patient's weight, etc. And the machine will calculate what amount of apheresis do. And it just does RBC apheresis, so there is less of volume load and overload to the patient. And it's dramatic. Patient comes at night with acute chest syndrome, breathless, sinus. You think that you're going to lose the child, and you start apheresis, within 4 hours he's walking in the ward. So that is the dramatic relief which you get. I think these are the remarks on the cases. I think now there are lots of questions on the chat box. So Dr. Kundan, I would request you to take them
Yes,
one
sir.
by
Yes,
one
sir.
and direct
First
it to
question
the
is,
one of the speakers. Yeah.
yes, antenatal counseling in hemoglobinopathies.
Atish.
Antenatal
So,
counseling in hemoglobinopathies.
antenatal counseling is very important, not only by the hematologist, pediatrician, but I take opinion from the geneticist also nowadays, or fetal medicine expert. It's very important that both the parents should have their genetic confirmation done, particularly if it is thalassemia, because when we send to fetal medicine expert, they need the trio. So for the child also, because most of the times what happens, only in particularly in our area, if mother is suffering from when mother is pregnant, they get only sickling test done and not the HPLC. And unfortunately, if it is negative, but we know that in sickling 15%, 40% of the patients in AS can have sickling negative, that they do not get the HPLC of the husband. So I think that is where we are still lacking. So now we are urging most of the platforms that HPLC should be mandatory in antenatal, in every antenatal woman, like we do HIV. HPLC should be done, because we see so many patients coming to our OPD and asking, sir, हमने तो sickling किया था. I think that is additional thing what I would like to tell here, and lot of other things. I think
I
fetal
think essentially genetic counsel is premarital counseling in high risk community nowadays in every mother and child.
yeah.
Post, if they find, check the father. If both are minor, do their genetic analysis to find the mutation and check for that mutation in every pregnancy, and extended family screening so that brother, sister on each side can then be counseled to prevent birth of that one thalassemia major child. Next question.
Dr. Suresh Sharmani has asked, can it be possible to offer BMT in splenectomy patients?
Absolutely.
Splenectomized patient, Dr. Adish, yes.
Absolutely, we can take them for transplant. Yes, but with specific like immunizations earlier and all, we can definitely take.
Remember, nowadays splenectomy is rarely required in thalassemia major children. If you
Yeah,
have
but
transferred them
sir,
well, you can actually not make out. They don't
yes,
have liver, spleen, no bony change. You can't make out that they actually thalassemia major.
yes, sir. But unfortunately, in Vidarbha region, I see
Yeah.
so many splenectomized, sir. So many patients they are splenectomized before coming to me. Like 7 years, 8 years, they are splenectomized. There
Correct.
are camps for splenectomy. I'm so surprised, but still, the things are bad, pretty bad here.
Just to add to what Atish is saying, I had a newborn who came for jaundice, as Dr. Lisa showed, and the child actually obviously had congenital spherocytosis. So I asked, he said the mother has undergone splenectomy. I said for what? He said no, उसका खून कम था तो सर्जन ने बोला इसका spleen निकाल दो. He had not even done spherocytosis test and not counsel and not given pre-splenectomy vaccine and
Vaccine.
post-splenectomy penicillin prophylaxis. I mean, it's unbelievable. This can happen even in a city like Mumbai. So we are far, far away from what is ideal. Next
Agreed.
question.
Next question from EB Malaika Kulkarni. Can a matched sibling who is sickle cell trait can be candidate for donor for sickle cell disease?
Yes, yes, it can be done.
Yes.
Definitely, we have done multiple transplants, and yes, we have to counsel them that yes, many times they are absent. Most of the time they are normal. Very few
Correct.
patients can have some symptoms, so we should counsel and we can take them as a donor. Not a problem.
One more question. Nitin Shah sir has just answered in his expert comment. What is the role of therapy which include thalidomide, hydroxyurea, and somewhat
Ah,
grass extract?
Lisa also
Sir has
mentioned they
very
are
nicely put.
experimental, they
It's
are under
experimental.
research protocol, they should not be standard of care. Please don't do it. If some mishap happens, you will be liable for medical legal
Yes,
case.
sir. And most of the patients, like I would add to it, sir, most of the patient that I see in my practice, which we come from such therapy, they have either dilated cardiomyopathy. Many patients, 3 to 4 patients I have found out, because their hemoglobin was they kept 6, 7, and they, the stunted growth, and then they have advised the same people have advised transplant subsequently. Most of the patients.
Yeah. One more question from Dr. Sanjay Joshi sir is that any validated transcranial Doppler values in adolescents age group to predict stroke in children and adolescents? They have values for adults. It is very effective non-invasive tool to predict strokes.
Yes, I think the Doshi sir is expert on this.
Yes.
He can, we can talk about it. Sir, would you
Yes.
please explain about like
Yes,
children
sir.
So,
and adolescents?
one thing is there are
And
very
we,
few centers who can actually do a proper TCD. Remember, sir,
Yes, yes,
any and every surgeologist cannot do it. We have a few centers in
yes.
Bombay. I'm sure they'll. If you've done in children, then of course that's one way you monitor their chance of getting stroke. Dr. Joshi can elaborate.
yes.
Sir, actually, Dr. Sharma from Chhattisgarh, he has done an extensive work in the
Yes.
adult population, and I think there are some centers from Mumbai. They have validated few studies
think we have lost his links. Dr. Sanjeev, you can put off your video, then we will hear you well.
In recent age to this skill of transcranial Doppler. Because in our demography, sir, we see left and right sickle cell every day, every month. We diagnose one or two patients. So that is the need of the hour. And since with the good supportive care, with the early introduction of hydroxyurea, the life expectancy of the sickle cell has increased. And once they grow up, the most important issue they face is the stroke.
Correct.
So I will request Nitin Shah sir to explore this particular
No, so
area.
if you
And
have the TCD which shows that it is now going to be threatening to go stroke, such patient
yeah,
when they are on hydroxyurea, it should be taken on transfusion and then maybe
yeah,
prepare them for transplant and hand over to
yes,
Akish.
yes,
I think that is what
yes,
is the triage I would follow.
yes, sir. And about
Because
the
once a stroke
fear,
develops, then you start transfusion therapy, then it's too late because their stroke may
yes,
not
too late.
recover. And many of
Yes,
them
sir.
can develop moya disease without even our
Correct,
knowledge.
sir.
So I think you have
Yes,
to be
yes,
very careful.
yes,
Absolutely, yes.
sir.
Next
Yes.
question,
And
Kundan.
Sir, almost questions have finished. We
All
are
right,
already
okay.
10:30 and
sir,
almost 40 to
just
50 people are still
just
joined online. Out of
Yes,
from
10 will
yes.
be
Nitin
given
Shah
by Dr. Bhupesh.
sir,
Yes, sir.
just one query to Dr. Nitin Shah sir. Sir, will you please explain this hepcidin concept to the our audience, August audience, like?
So when we were students, we were taught the mucosal block theory to say how iron is absorbed or not absorbed, when it is required and not
Yeah,
required. That mucosal block is the hepcidin hormone which is released essentially by liver. So when the
yeah,
iron is required because of anemia, hepcidin is low. So when hepcidin is low, it allows trans membrane transfer of iron at the duodenal and the small intestinal epithelial cell level, basal level. It also will then open up the ferroportin pump so that iron is thrown out from the enterocyte into the circulation, from the liver into the circulation, and ultimately reaches the bone marrow or the reticular endothelial system for utilization. And when iron is not required, as it's toxic to the body, it is blocked by having high hepcidin, which will block the iron absorption at the enterocyte level, block the iron release at the RE system as well as the liver system. Now, when your inflammation, like in JRA, malignancy, so many other things, hepcidin is high because it's a pro-inflammatory marker. So even when there's anemia, because of high hepcidin, iron is not absorbed, iron is not released, it is trapped as hemosiderin, and ultimately bone marrow doesn't have iron. So you have plenty of iron in the body, but not available for the iron to be utilized in the marrow. So you can overcome this by anti-hepcidin molecule, which are of course still not available, but by giving IV iron, which will overcome the absorption pathway and lead to some anemia. I mean, correction of anemia. I think that is in essence what the hepcidin is. And of course,
thank you so much.
hepcidin is very, I mean, hepcidin also is involved into hemochromatosis, where, you know, the
Hemochromatosis,
unnecessary
yes,
iron
yes,
absorption from the intestine is because of the defect in the hepcidin molecule
yes,
production,
yes,
genetic at different levels.
yeah, yeah, yeah.
Yes. Vote of
All
thanks
right.
by Dr. Bhupesh, sir.
I think Dr. Bhupesh, maybe you can put off your video because your bandwidth is probably, we're not able to hear
और
you.
नितिन सर आपको याद होगा बहुत हाई प्रोफाइल केस था दो ऑलमोस्ट 2 डिकेड पहले यूनियन मिनिस्टर मारन उनका ऑटोमेटेड इसमें मशीन पे ये किया गया था बट पीएस देखा नहीं गया था सो द ल्यूकेमिया वाज मिस्ड
Ah, right. I'm telling you, pathologists have hardly any time to even sign their reports so that they
Yes.
now have printed signature. Who's going to see the smear? Yeah, Dr. Bhupesh.
And to thank the expert Dr. Nitin Shah for his timely and precise expert comments. Also, I would like to thank Dr. Rajesh, Dr. Tushar sir, and Dr. Neetu madam for their wonderful presentation. I also like to thank obviously President Dr. Sanjay Doshi sir, Secretary Dr. Neetu madam, Vice President Dr. Anup Pal, Dr. Vinayak Katti sir, Dr. Malina sir, Dr. Nikhil sir, and our scientific madam, Dr. Christine Yadav sir, then Chairperson Yadav sir, and Sanjay Patil sir, and all participants. present. Last but not the least, Malay madam for the supports. Thank you. Thank you.
Thanks all.
Thank you,
Thank you
Thank you
everyone,
all.
so
for
much, all of
giving me
you.
this opportunity.
Thank you, sir.
Still talks by
Thank
three
you,
young
Nitin sir,
people.
for joining.
Thank
Thank
you,
you.
sir.
Dr.
Thank
Atish,
you, sir.
very good presentation. Dr. Tushar and Dr. Lisa, excellent. All are now becoming detectives now. So in the
ये लोग
next few
दादा
days we'll
दादा
come up.
सब लोग दादा हो गया, अभी दादा हो गया.
सर आपके ब्लेसिंग है.
अरे, अभी हम रिटायर हो गए सर.
नहीं सर. Thank you,
चलो
sir.
everyone,
Thank you
good
so much.
night.
Good
Good
night.
Yes, sir.
night.
Thank
Good
you.
night.
Good night.
Good night,
Good
good
night.
night all.
Good night.
Good
Good
night.
night.
Thank you,
Thank you all.
Kundan and
Thank you.
Bhupesh. Yeah.
Thank you so much.